one drug or no choice at all to 2, 3, 5, 6 drugs and combinations of such as well. It can be a bewildering effort to try and figure out what needs to be done. Being able to help our patients make choices for themselves can make a big difference. And all those years has given me a breadth of experience, I think, to be able to know that I've seen various shades of how cancer issues may present and how to deal with issues of such for patients and their families. It brings me joy to make sure that I can get them through those tough periods, knowing that we've made a difference that day, made a difference that week, and made a difference for the patient and their families.
Salam sehat teman Gracia, mau medical check-up atau berobat di luar negeri? Gracia Care Global akan membantu Anda dalam memberikan referensi dokter dan rumah sakit yang paling tepat. Nah, melalui GCG, teman Gracia akan mendapatkan pelayanan prioritas seperti layanan konsultasi dan bantuan booking janji temu dokter. Gak hanya itu, GCG juga akan membantu proses perjalanan Anda dari awal loh. Mulai dari pemesanan tiket pesawat, hotel, dan penjemputan di bandara, sampai pembelian asuransi perjalanan. GCG juga menyediakan layanan pesawat charter bed-to-bed yang berkualitas. Buat teman-teman Gracia Care yang suka jalan-jalan, gak perlu bingung. GCG membuatkan itinerary atau panduan perjalanan yang berisi jadwal janji temu, tempat-tempat wisata, dan juga kuliner. Setelah selesai berobat, untuk teman Gracia yang memakai asuransi, GCG akan membantu mempercepat proses penjaminan dan memastikan dokumen-dokumen yang kamu perlukan dari rumah sakit lengkap. Jadi, teman Gracia nggak perlu repot deh.
Thank you Gracia Care yang sudah membantu saya dan keluarga besar saya dari Jakarta, Malaysia, Penang sampai ke Singapura. Saya dan keluarga besar saya merasa terbantu banget sama fasilitas dari Gracia Care. Ya awalnya kita nggak ngerti cara daftar gimana atau dokter mana sih yang terbaik buat keluarga saya. Gracia Care sangat membantu dan juga menjawab segala kebutuhan saya. So thank you banget buat Gracia Care. Dan jangan lupa dengan menggunakan fasilitas Gracia Care dapat diskon loh. Bahkan saya dapat update tambahan kelas nambah lebih baik lagi. Thank you banget buat Gracia Care. So buat teman-teman yang masih bingung, ragu pakai Gracia Care atau tidak, jangan ragu karena saya dan keluarga besar sudah memakai Gracia Care. Thank you.
So how I became an oncologist has a very personal touch. My mother was diagnosed with cancer many years ago. And that whole experience and journey, was touching and revealing, and it showed a different side of medicine, which, made a big impact on me. The thing that stood out in oncology care was that it's definitely a journey that the patient and the family embark upon as well. So I've seen the changes in oncology over the past 2 decades. From a single choice of one drug or no choice at all to 2, 3, 5, 6 drugs and combinations of such as well. It can be a bewildering effort to try and figure out what needs to be done. Being able to help our patients make choices for themselves can make a big difference. And all those years has given me a breadth of experience, I think, to be able to know that I've seen various shades of how cancer issues may present and how to deal with issues of such for patients and their families. It brings me joy to make sure that I can get them through those tough periods, knowing that we've made a difference that day, made a difference that week, and made a difference for the patient and their families.
Good evening everyone, selamat malam Bapak Ibu dan rekan-rekan sekalian. Welcome to Gracia Care Health Talk with Icon Cancer Center. Terima kasih sudah hadir dalam kesempatan kali ini. Di tengah kesibukan teman-teman di sini bisa menyempatkan untuk hadir di webinar kali ini, bisa menyempatkan mungkin di sini ada yang udah pulang kerja atau selesai beraktivitas atau lagi lembur nih di kantor. Gracia Care siap menemani teman-teman semua di sini. Apa kabarnya semua? Semoga dalam keadaan sehat di musim yang memang mulai transisi dari musim kemarau ke musim hujan. Jadi teman-teman di sini semoga dapat menjaga kesehatan agar bisa menjalani aktivitas sehari-hari dengan lancar dan sehat. First of all, let me introduce myself. My name is Riri as the representative for Gracia Care for today's health talk with Icon Cancer Center. Okay, so today Gracia Care bersama Icon Cancer Center akan mengadakan webinar bertemakan colorectal cancer, yang mana hal tersebut berkaitan dengan organ yang letaknya saling berdekatan nih di dalam perut, yaitu pankreas dan usus besar ya teman-teman Gracia. Kedua organ ini juga sangat sering bisa terserang penyakit kanker. Jadi bermanfaat sekali ini tentunya kesempatan webinar bersama Icon Cancer Center ini. Pastinya Riri nggak akan sendiri di sini. Kita juga akan ditemani oleh Dr. Robert Lim as senior consultant, specialist in medical oncology. Jadi yuk siapkan pertanyaan-pertanyaan kalian seputar kanker pankreas maupun kanker usus besar. Akan ada juga free bakpao binjaiban bagi kalian yang perdana nih untuk mengikuti Gracia Talk kali ini. Nah, oke, sedikit highlight untuk background dari Dr. Robert Lim yang akan menjadi salah satu narasumber kita hari ini ya teman-teman. Gracia, jadi Dr. Robert Lim ini memperoleh gelar medisnya dari Universitas St. Andrews and Universitas Edinburgh. Beliau kemudian pindah ke New York di mana dia menyelesaikan pendidikan spesialis penyakit dalam, dilanjutkan dengan pendidikan spesialis hematologi dan onkologi medis di New York Hospital, Fakultas Kedokteran Cornell University dan Memorial Sloan Kettering Cancer Center. Dr. Lim juga merupakan Fellow of the Royal College di Edinburgh. Sekembalinya ke Singapura pada 1998, beliau telah mengembangkan minat klinis khusus pada kanker saluran pencernaan hati dan pankreas. Nah, oke. Di sini mungkin Bapak, Ibu, dan rekan-rekan di sini sudah mendengar mengenai Gracia Care, bahkan mungkin juga sudah ada yang menjadi member Gracia Care. But for those who haven't heard about Gracia Care, I would like to introduce it first. So basically, Gracia Care is a medical assistance, di mana kami adalah jembatan bagi masyarakat dengan rumah sakit, baik untuk rawat jalan maupun rawat inap. Gracia Care membantu dari awal admission sampai dengan ketika akan pulang dari rumah sakit. Nah, jika Bapak Ibu perlu mencari referensi dokter misalnya atau referensi rumah sakit, kami akan siap bookingkan. Jika ada yang perlu rawat inap, kami siap carikan, karena yang namanya penyakit, who knows, kita tidak ada yang tahu ya teman-teman Gracia, namun tenang aja, Gracia Care akan membantu menjadi jembatan bagi teman-teman Gracia di sini untuk kebutuhan medis teman-teman Gracia dari awal sampai akhir. Dengan adanya Gracia Care, teman-teman tidak akan sendiri dalam proses rawat jalan hingga rawat inap. We will assist you wholeheartedly, and Gracia Care has more than 100 partners for hospitals and clinics, and of course we will continue to grow in terms of services to the community. Okay, now back to our main topic. Once again, Gracia Care bekerja sama dengan Icon Cancer Center membawakan health education dengan tema colorectal cancer. Okay, so excited that we are gonna be accompanied by Dr. Lim as senior consultant, specialist in medical oncology. Hello, Dr. Robert, nice to see you. Terima kasih sudah bisa meluangkan waktu. Thank you for your time and this opportunity. untuk kita bisa berbincang-bincang di Health Talk hari ini dan memberikan health education untuk kita semua. Maka dari itu, kita sambut pembicara kita di Health Talk with Icon Cancer Center. So please welcome Dr. Robert Lim to present about our main topic for today, yaitu colorectal cancer. Nah, mungkin dari teman-teman Gracia di sini yang mau mempersiapkan pertanyaan-pertanyaan kepada Dr. Robert Lim, akan kita jawab di sesi Q&A. So, hello dokter.
Hello. Yes, thank you
How are
for
you, doctor?
inviting me. Yes. I
Well,
hope
thank
this
you
evening
for
will be helpful and
taking the
fruitful
time.
for everybody. Okay, are we ready to start yet?
Yes. Jadi boleh dari sini teman-teman Gracia mempersiapkan pertanyaan-pertanyaan yang akan dikasih ke Dr. Robert Lim. Okay, shall we start, Dr. Robert Lim?
All right, thank you.
Okay.
Good evening, everyone, and thank you for joining us and spending this time this evening with I wish to share things that have been going on in colorectal cancer. I think there are many important new advances which can be very helpful for you all to know. So next slide, please. So brief outline is essentially, very, very briefly, some surgical options. Now, I'm a medical oncologist, so I will only touch upon some basic issues here, not go into any great details about surgery, about how we might lower chances of recurrence after surgery. And also sometimes we may do such treatments before surgery to shrink or downstage cancers to make surgery easier, perhaps. And then also an important section in terms of treatment for advanced disease, metastatic disease. Next slide, please. So here you can see that colorectal cancer, like in many other countries, Singapore included, and in the Western hemisphere as well, colorectal cancer is unfortunately a common problem. Second most common cancer in Indonesia for males. Next slide, please. And third most common for females. So it is, undoubtedly, something extremely common. I often do see patients being diagnosed with this from Indonesia coming across for treatments and opinions and such like. Next slide, please. Briefly, what are some of the risk factors? So one risk factor, which as you can imagine, we can't change, is the issue of aging. And actually aging obviously is a major risk factor for all cancer problems, and including cardiovascular disease. Now, the issue of whether red meat, processed meat can increase risk, well, perhaps so. These are mostly what we call observational studies. There's some general consensus agreement that a modest consumption in the setting of what we call a balanced diet is most appropriate. Smoking, of course, is a risk factor for many issues, including this sort of cancer. Alcohol consumption has been linked as well. More and more, we see that evidence of obesity and lack of physical activity, lack of exercise can be an important risk factor for many cancers, including this as well. And for some patients who have had a history of what we call inflammatory bowel disease, like this Crohn's disease, ulcerative colitis, this can also have a risk for colon cancer. Next slide, please. What are some symptoms that may occur at times? Well, change in the bowel habit, if you've been very regular, and then you form diarrhea and then constipation as well, these are problems. Noticing blood pass in the stool, a sensation of constantly feeling that you need to pass stool is called tenesmus. These are some of the possible symptoms. But also, unfortunately, more advanced disease may be heralded by things like pain, weight loss, inability to pass motion because the tumor may be so big as well. Now, in some families, where maybe colon cancers have been diagnosed in other family members, especially at a younger age, less than 60, there should be a greater awareness of the possibility of developing colon cancer. And in such families, we actually have a lower threshold to start evaluating suspicious symptoms, and also in early age to start screening. Next slide, please. So if it's a cancer, what about surgery? What can we do in that sense? What are the options? Next slide. So in brief, some of the key things here to keep note of, high quality surgery is very important, and now especially when it comes to an issue of the rectal cancer, and I'll show that in a while, why this concept of what we call total mesorectal excision or good high quality surgery of this sort is very, very important. And in that sense as well, also that the surgeon does a good job and the pathologist to examine the specimen taken out to make sure at least 12 or more lymph nodes around the colon cancer have been removed, so that your staging is proper and adequate. This is a very well established fact. And nowadays, for quite some time, laparoscopic, or what we call keyhole surgery, is now very widely accepted and used. Next slide. So this diagram illustrates, I hope you can see this on my cursor here, the outline of a rectal tumor in a side view, or so to speak. And this dotted line forms the area of what we would call the kind of surgery that would be called the proper surgery, called total mesorectal surgery. So there's this fatty tissue just next to the tumor where there can be tumor deposits as well. So, proper removal of this by an experienced surgeon is very important for the best outcomes in this scenario. Next slide. And in terms of these improved surgical techniques, I mentioned laparoscopic keyhole surgery, and at times, in certain instances, maybe even robotic surgery. And even for advanced colon cancer, where maybe the colon cancer has spread, especially to the liver, there can be a role for surgery to the liver as well. And I'll come to that as well later. Next slide. In medicine, we often look at these sort of charts or graphs to understand how things turn out. And essentially, these are the graphs where these curves, these lines are very much on top of each other, superimposed, mean that there's really no difference. So this is what it means, that in terms of whether you have a big cut with what we call open surgery or versus keyhole type surgery, the issues of survival of the patients are actually similar for colon cancer or rectal cancer. Next slide. And in terms of the possibility of recurrence, distant recurrence is also very similar. So essentially, laparoscopic surgery in experienced hands is an appropriate and good option to have. And why? Next slide, please. Well, the benefits are you have much smaller wounds. You have these small cuts, and I'll show some pictures as well. And so with smaller wounds, you have less pain, shorter hospitalization period, and actually the bowel movements return more quickly. So overall, you have a quicker recovery as well. Next slide. This is what, how surgeons work this as well. It's just that they work on the outside looking at the screen with their instruments pointed into the tummy to do their work. Next slide, please. Yeah, just next again, please. One more. Thank you. So this is the traditional way of old surgery, and sometimes may still be necessary. Open a long incision, long cut down the abdomen this way. Press once, please. Next slide. And this is how an laparoscopic surgery result might be, that the incisions, the cuts, so one small one at the belly button, umbilicus, and then here a small on the left side and the right side of the small incision. So you can imagine that the recovery is faster, actually less discomfort. And where sometimes we need to get some chemotherapy going soon after that, it can be sooner than with an open wound issue as well. Next slide, please. Now, after surgery, we then examine the specimen to try and find out, we want to know what is the tumor type and also definitely what stage. So thank you. So the key thing in this instance for early stage colon cancer is stage 3, where the surrounding lymph nodes may be affected, one or more. And this is an issue because we're concerned. Next slide, please. We are concerned. Why? Because cancers can recur after surgery. Why do they recur after surgery, even though we don't see anything else on the scans or after surgery? Because there can be microscopic disease left behind. The lymph nodes that are present are a sign that things are beginning to extend beyond the colon itself, and this is a risk, and we know this issue for a long time. Currently, we are unable to confirm for sure, whether this cancer will definitely recur after surgery, although there are some interesting developments which I'll come to later as well. But since the 1990s, we have been given chemotherapy for stage 3 cancer, especially. We decrease the recurrence rates and improve survival. So we're actually increasing the cure rate. And there have been further refinements in these treatments I'll come to very shortly. Next slide. So an important study that I was involved in, published way back in 2004, showed that beyond the traditional 1-drug treatment, a 2-drug treatment with the addition of a drug called oxaliplatin, further improve what we call the recurrence rates, lower recurrence rates. This is what we call disease-free survival in the yellow curve, and that was associated with improvement survival as well. And this still remains the standard of care, a 2-drug treatment for stage 3 patients. But there have been further refinements. Next slide, please. Yeah, combination. Thank you. Next slide. So an important consideration of some years ago was, can we actually do with 3 months less treatment versus the traditional 6 months of treatment? Because sometimes with these treatments, you can get side effects, especially with oxaliplatin, numbness, that can be long lasting as well. And in this particular study, what was found, you can see these curves. Again, you see they're virtually on top of each other, identical. Next slide, please. And so essentially, what we now know is that this is from a 12,000 patient data set as well. Excuse me, that normal risk stage 3 colon cancers, that 3 months of such treatment is actually equivalent to 6 months with less toxicity. So we importantly want to understand the situation for the patient, so we can guide them in terms of making decisions like this, which can have a long-lasting impact because of the possibility of numbness that can stay a long time if you give too much of this treatment. Next slide. Now, I was alluding to this again in terms of the rectum. It's a unique area because it's down in the pelvis, and you see on the slide here on the right that it obviously comes to the anus, where it controls passing the motion as well, the muscles there. So you need a functioning anus as well to do this job as well. So very important that the treatment for the rectum is done properly and appropriately to have the best outcomes, not just in terms of the cancer situation, but also in terms of quality of life as well. Next slide, please. So this is what a scope view of a tumor could look like. A very essentially ugly looking thing is almost blocking the passage of the scope in this view. Next slide. And what we know now is that actually for rectal cancers, actually we very often will give radiation and chemotherapy, plus or minus more chemotherapy, before surgery. So you see on the left, a rectal tumor. This is the contrast. This is in the white. So the big rectal tumor taking up space here. And after treatment with chemotherapy and radiation, it is much better as well. Why might we do this? Next slide, please. So another view, a side view of it. So a big, you can see a big rectal mass here, right? This is the spine coming down, tailbone, right? And so after treatment here, you see it's shrunk a great deal as well with the chemotherapy and radiation. Next slide, please. So why might we do this? Click once, please. If you see here that before surgery, preoperative chemotherapy with radiotherapy versus post-operative, you see that after surgery, you see there are more earlier stage tumors if you give the preoperative before surgery treatment as compared with going straight to surgery. Okay, next slide. And click once. So the other issue here is that if you give preoperative treatment as well, there's a higher chance that you can save the anal sphincter preservation of that. So less patients need permanent bags or colostomies as well. Next slide. And here, this is just to illustrate that in terms of side effects or toxic effects, both the immediate acute and the long-term chronic side effects of preoperative chemotherapy and radiotherapy are actually less compared with giving it after surgery. Okay, can you click again and again and again? Okay, just to illustrate that the side effects are actually better handled if you give it before surgery. Next slide. How about outcomes in terms of survival recurrence? You can see they're actually very similar. So it is you do not make the situation worse for the patient by giving it before. You don't make it worse by giving it before surgery. Traditionally, in the past, many years ago, we were giving it after surgery. So giving it before surgery is definitely the way to go. In fact, all the major guidelines, the American, the European guidelines, all essentially say that, we should be giving preoperative chemotherapy and radiotherapy to our early stage rectal cancers and not surgery first as much as possible. Next slide, please. So in terms of this preoperative, or with the other medical term we use for this is neoadjuvant treatment for rectal cancer, what are the possible benefits? I've mentioned some of them, but obviously there's also the improved chance of complete resection of the tumor, especially if it was initially very big, bulky, and the surgeon knows that they will not be able to achieve what we call negative margins. You would definitely leave cancer cells behind. So doing this can shrink it down to do that. Improved chance that what we call the anal sphincters can be preserved, so we don't need to have a permanent colostomy bag. Improved chance of what we call a pathologic complete response. That means when they actually resect, take out the rectum, there's actually no cancer cells left, and these patients have a much better prognosis overall. And nowadays, in fact, we also just can increase the pathologic CR rate by giving what we call total neoadjuvant therapy, TNT, which is basically radiation with chemo. And then in the waiting time for the radiation to take effect, I give more chemotherapy and you have a greater shrinkage. Can you click once, please? Click twice here. So just to illustrate that, from group 1 to group 4, these patients all had radiation and chemotherapy, and then different degrees from less chemo to more chemo, and you see that there's a higher pathologic response rate with more chemotherapy. This is a very important consideration. Next slide, please. It has evolved even more. This year, this was a study that many of us, including myself, were keenly awaiting. This study conducted in America was looking at the issue of, does every patient need radiotherapy? So in this study, you can see that this is randomization to either receive the traditional control chemotherapy with radiation, and then they waited and then went on to surgery, followed by maybe chemotherapy after that, versus chemotherapy alone first, and then they checked what had happened. If there was a response shrinkage of at least 20% or more, they went straight to surgery and then maybe more chemotherapy, therefore no radiotherapy. Or of course, if they didn't have such a good response, then they went to the radiation phase with chemotherapy and then to surgery itself. Okay, so can we do without radiotherapy for a certain group of rectal cancer patients? Next slide, please. And this was published in the New England Journal just in June this year, right at the time this paper was presented at the American meeting. And these graphs basically show that the outcomes were the same, but essentially, click once, please. One of the major findings of this was that for those patients who received just preoperative chemotherapy, 90% did not need radiotherapy. So this is something that nowadays I definitely would discuss with my patients to say, you could consider getting, if they are suitable, just chemotherapy. And, and if there's a 90% chance that they may not need radiotherapy, which is a good thing in a certain way too. Next slide, please. On to very advanced metastatic cancer. So this is an old patient of mine many years ago. The tumor had spread to the lungs, these tiny little dots all over the lungs. Next slide, please. And after chemotherapy, a much improved situation. Next slide. And in the liver, this is what a PET scan would show of spread to the liver. These bright yellow spots are the PET avid tumors in the liver. And after chemotherapy, next slide, please. Again, a very good response in this sense. So we can definitely help patients. It may have spread, but we can definitely help them in a great deal. Next slide. So one important concept here is, making sure our patients have every chance to receive all the active drugs, chemotherapy or targeted therapies as well, and this is associated with the best outcomes, best chance of outcomes for them. Next slide. And nowadays, for a long time, you may have heard, we have a lot of targeted treatment options, molecular targets. So working from the left to the right, you see the antibody drugs, which sort of bind to the ligand. The ligand is what would actually stimulate the receptor, so you can prevent things happen that way. You can have antibody drugs in the second one here from the left. Antibody drugs which directly block the receptor. Thirdly, in the middle, you have TKIs are small drugs which actually block the enzymes in the signal at the receptor level. You have next to it, you can have nowadays drugs which bind to the receptor and bring a chemotherapy drug along to be more localized to the tumor, and I have an example of that as well. These are the main options that in terms of surface of molecular targeting. Next slide, please. So one of the targets we have in colorectal cancer is this epidermal growth factor receptor. So activation of the receptor can lead to a lot of signaling, which leads to cell growth, survival of the cancer cells, spread, different metastases, and blood vessel formation as well. Next slide. And so we have drugs which block this, and an important consideration here for metastatic colorectal cancer, next slide, is to actually check. We do testing of the tumor cells for genes, the RAS and the RAF, the RAS and RAF genes. Why? Next slide. Because if you have mutations in here, it's like the switch is left on the inside, even though if you block on the outside, there's no effect. So actually looking at this gives us important information to know whether such antibody drugs, whether it should be used. If you have a mutation in here, then we would not waste time and money using that. We're better able to select patients that will benefit from this sort of treatment. Next slide. And targeting the blood vessel system as well is important, because that as tumors grow, they need blood vessel supply to actually give them blood and nutrients and that kind of stuff as well. So targeting the blood vessels is an important part of our treatment. Next slide. And how does it work? It basically normalizes an abnormal blood vessel system within the tumor to make it more normal. And importantly, what it does, has been found, is it actually increases chemotherapy delivery so that the effect of the chemotherapy is enhanced that way. Next slide. So all in all these newer treatments and things we're doing have actually helped us increase even higher shrinkage rates and control rates for colorectal cancer that has spread. Next slide. I mentioned this earlier about the liver. Okay, so metastatic colon cancer, if it's only to the liver, it may be the only site. Why? Blood from the intestines goes to the liver first. So sometimes if we only detect it in the liver, that may be the only site of spread. So what can we do for that? And there's been a lot of data for many years now, 20, 30 years or more, to show that if you select our patients well and properly, surgery to remove the tumors in the liver for some patients can be beneficial. Next slide. We understand the anatomy of the liver, so we know how much which segments, which lobes they are. So the liver surgeon knows how to perform surgery, taking into account the blood vessels around it as well. Next slide. And this is just to illustrate from the curves from the very far left, where this is just no treatment in the past, to the second curve in green,
where it's just one chemotherapy drug alone. That was the basic treatment in the 90s, actually, 80s and 90s. You see some improvement in survival, and then double drug chemotherapy improved things further. But what's been shown now is that at the far right, if you have patients with liver metastases from colon cancer that can be removed surgically, they have the best chance of 5-year survival and long-term survival. And the next curve just below that, where you see this 33%, these are patients where they may not be removable or resectable initially, but after chemotherapy, we can get them to the surgeon to remove that, and they have a much better chance as well. Next slide, please. So like in this instance of, spread, these dark spots on the CT scan show spread to the liver. Okay, next slide. Right, and next slide, please. After chemotherapy, you see, next, just press once, you see a very good response. And this patient now, it might be suitable to go on to remove the residual remaining spots and can in the liver and can benefit from that. Next slide. So just to illustrate over the years, these are survival curves from the 90s to just up to 2006. Over the years, from left moving right upwards, and patients are doing better. More patients are living longer. Next slide. And the reason for this, next slide. The reason for this is, first of all, more patients being able to get more active drugs and more active chemotherapy treatments. And also proportionately, the data show that more and more patients were getting surgery to the liver as well. Next. Now, if surgery to liver is not possible, but lesions are small enough, we can do other things, sometimes liver-directed therapy. So radiofrequency, or sometimes there's also a technique of microwave ablation, using needles put in there and heat and burning these areas. So these are other options. Next slide. And through the arterial, arterial system to get to the tumor and give little beads with little radiation. We call it SIRT or radioembolization. These are some of the other options, sometimes beyond surgery. Next slide. Now, other things, how about, taking care of the patients, not just about all these treatments, obviously giving them the proper good psychological support, the emotional support. I very much believe clear explanations and plans make a big difference. So everyone knows and understands why we're doing this, and how to deal and cope with certain issues. Eating right, obviously, and teamwork. There are many people involved in taking care of the patient. Next slide. This is just to illustrate an old patient of mine. You can see this is the liver tumor, all these dark spots here from left to right, and he had a very good control with this treatment. Next slide. This was a tumor in the adrenal gland, where the red arrow shows, and it shrunk very nicely with the treatment as well. Next slide. And just a lung spot as well, which also shrunk very nicely with the treatment. Okay, next slide. Okay, just click along the way, please. So this patient was diagnosed, December 2012. We gave him his initial treatment. He actually got better because all of his symptoms got better. He had no significant problems with the treatment. He had surgery for his tumor as well. Then later on, of course, he required more treatment. He got to enjoy his 80th birthday, enjoying, meeting his friends, family, his golf as well. And yes, later on, essentially, it got to a point where it got worse again, next one. And he passed on literally 3 years to that point. Now, with the extent of his problem you saw on the scan just now, if we had not done this, please click. I think if he had not received these treatments, I think he may not have gotten to this point as well. Click again and again. Thank you. So next slide. Okay. So an important consideration here is also we strategize. What are we aiming to achieve, and what is the clinical situation? What is needed, and how intense should the treatment be? So if you have, liver spread, and is potentially resectable by surgery, and you want to shrink it as good as possible, so we may give stronger upfront combination treatments to get a better chance of shrinking it. Or if you have a patient with a lot of tumor which is rapidly progressing, a lot of symptoms from the cancer problems. And, you want the maximum shrinkage, possible, so you may do that. But if you have maybe a situation where there's no possibility for surgery for the tumor and not as much symptoms, if they're less well, not so strong, more frail, then, lighter treatment as well may be also suitable to prevent significant toxicity. Next slide. Now, what's new on the horizon? We'll finish off with this section. Next slide, please. You've all probably heard a great deal about immunotherapy, cancer immunotherapy. It is definitely something that we aim for in as much as possible in suitable patients with the right conditions and such like. Next slide. So the current drugs basically, act, click twice please, act on this sort of brake system, the PD-1, PD-L1 system, which are the brakes of the immune system. So if you inhibit that, then the cells sort of wake up and are meant to do that job. Okay, so tumor cells have often found a way to actually sometimes block some of these signals. Next slide. And actually, you can't see it so well. I'm sorry, it's very small, but one of these immunotherapy drugs, pembrolizumab, Keytruda, was established to be used for a specific genetic feature called MSI, microsatellite instability high. Next slide. And in this particular study, they actually looked at MSI high colon cancers, which was spread, and half of them received immunotherapy, pembrolizumab, and half of them received traditional chemotherapy. And you see that in terms of the progression-free, that means the patients who did not worsen, more patients who received the immunotherapy did better. So definitely, this is the best option for such patients with MSI high colorectal cancer. Next slide. And in terms of other targeted treatments, for a molecular feature called BRAF mutation, this study basically compared targeted therapy with chemotherapy with itself. Next slide, please. And you see that basically with the targeted therapy in the blue bars, whether it was a 3-drug targeted therapy or 2-drug targeted therapy, they did better than the traditional chemotherapy. Next slide. And another targeted treatment you may find perhaps surprising in a way is using even breast cancer treatments for colon cancer. So in some patients where this HER2 receptor is overexpressed, this might be an option. Next slide, please. So this is what a HER2 receptor is, as a growth receptor on the surface of cancer cells, similar to breast cancer patients who have the same thing. And the signaling from this also will stimulate the cell essentially to grow, divide, etc. So targeting this has become an option. It's not many. Next slide, please. Though it's not. It's only a small proportion of patients who have this possibility, but we'll look out for this as well because it can make a big difference. And next slide. And this is the study that sort of showed. So this on the left, you see this is what we call a waterfall plot. As you can imagine, like water going over the edge. And each of these bars, you see, is actually an individual patient. So you can see the majority of patients in the study had shrinkage of tumor, right? And so it's very, very encouraging in this way. Next slide, please. Now, again, I mentioned this earlier, targeted therapy with a chemotherapy drug, attached to it. And now we have such a drug, this drug called Enhertu. So it's actually looking at HER2, the same HER2 receptor. So you have an antibody here with the chemotherapy drug, and it gets to the cell, and the cell actually tends to bring it in, gets absorbed, and actually helps kill into the cells. And then actually, when the cell dies, it releases that same compound, and that can have an effect on the nearby cells as well. Okay, next slide, please. Okay, I'll skip this. Next slide. And so similarly, you can see here in this, this waterfall plot, majority of patients you can see all have shrinkage of tumor, And as you know, so very, very encouraging thing. I think this is going to make a big difference as well for such patients. Next slide, please. Now, sometimes you may hear that doctors may talk about next generation sequencing. What is this? It's basically taking tumor tissue, essentially, mostly, and looking at the DNA and examining for what kind of gene mutations there might be to see whether a gene mutation present may in fact have a treatment that may be applied to it as well. And you can look for this in the blood. It's called a liquid biopsy, actually, looking for the cell-free or circulating tumor DNA. You can sometimes find it in there as well. So that's another option if you don't have tissue to look at as well. And how does this help? Next slide, please. Well, we get a report and we get, a report of telling us which gene mutations, etc. there may be. Sometimes or many times, in fact, some of these gene mutations may not have a particular drug available at this time, but sometimes these things that make an impact. For instance, in this particular report, it tells us there's an NRAS mutation. So use of these particular antibody drugs is not associated with benefit, and we wouldn't give that. Next slide. Thank you. Next slide. Last but not least, so very enticing, very promising data looking at this issue of looking at from the blood, looking for cancer DNA essentially in the blood. Can we detect it? Can we use this information to tell us whether patients after surgery do need chemotherapy or not? This is, is an evolving field. I do believe eventually it was going to be quite positive, but although we're waiting for the validation of this, so it's encouraging, and I think this will probably make its way into regular use in the future. But at this point in time, I caution that it's not something which is been completely validated, but something to keep an eye out for as well for the future. Next slide. Right, so some conclusions to share with you. Surgical techniques have improved greatly. It makes, how we can take care of patients in that way, quicker recovery. Chemotherapy after surgery lowers the odds of recurrence. Shrinking, downstaging disease can make it easier, less morbid for surgery, especially for rectal cancer. And in fact, some patients may now not need radiotherapy. Next slide. For advanced metastatic disease, our treatments, systemic treatments have improved. So our chemotherapy, such toxic drugs, we have monoclonal antibodies with different targets. We have immunotherapy options for some patients and other liver-directed therapies or surgery for advanced disease at times. So very much so, the investment in science is paying off. The options for many patients have improved a great deal as well. Next slide. And I hope you could see that actually tailoring our treatment is actually more feasible and very much a standard of care these days. Keeping sight of the aims of our treatment is extremely important, to provide that realistic hope for for what's happening, explaining the problem, working together for the best outcome for the patient and family, and essentially turning this to a bit more of a chronic disease than than before. Next slide, please. Right. Well, thank you very much. And this is my contact details. If you need the QR code as well, if you need that. Most happy to address whatever questions you all might have tonight. Thank you.
Okay, thank you very much, Dr. Robert Lim. A very insightful topic for us. And so, teman-teman Gracia, treatment yang jadi kesimpulan dari pembahasan kita kali ini, jadi treatment yang tepat sangat penting untuk pencegahan atau penyembuhan dari jenis kanker tersebut. And also there is so many options for every patient to have systematic treatments. As Dr. Robert Lim mentioned, there is already improved systematic treatments that already been improved significantly. Treatment untuk penyakit kanker ini sudah banyak opsinya ya teman-teman. Jadi marilah kita jadikan atau anggap penyakit ini sebagai penyakit kronis yang harus diwaspadai atau dicegah. A more awareness to colorectal cancer. So next, coming up to the most awaited session, to the question and answer session, Dr. Robert Lim. Jadi Bapak Ibu sekalian yang memiliki pertanyaan, tentunya bisa banget ditulis di chat box atau raise hand yang mau bisa menanyakan langsung ke Dr. Robert Lim. So we have already few questions here. So interesting. Riri juga mau ingetin lagi, kita juga akan ada hadiah berupa bakwan bincaban bagi teman-teman semua di sini yang hari ini perdana nih mengikuti Health Talk Gracia Care. Okay, so the first questions, I will start with Ibu Nita in the chat box. So she's asking if there's a level of severity of colorectal cancer that can cause a death. Dr. Robert Lim, maybe you can answer.
So, I think essentially if you have early stage colorectal cancer, that alone typically should not cause, we would not expect that to cause death, right? Unless that was some unusual catastrophic event itself. But so it's really the stage 4 disease where it has spread. And then also, therefore, it depends on where it has spread to, how extensive. One spot in the liver is stage 4. 10, 20 spots in the liver and the lung is also stage 4. So you can see there's going to be a big difference in that way. And so how this affects the patient, or in whichever way, it will be variable as well, because you can have patients who have been very well and fit and can tahan essentially a bit more stress to the system in a way, as opposed to someone who's more frail and not able to handle that. So there are differences. But essentially, it is always, generally speaking, advanced cancers which will cause the patient's deterioration and death, actually.
Okay, so the next question from still the same person, Ibu Nita ya. So does the symptoms of the colorectal cancer can be experienced by all ages, and are women more likely to get colorectal cancer than men?
Well, if you recall, or maybe if you've seen the initial slides I showed, certainly I tried to show as well some evidence from Indonesia, right? Because that's more pertinent for you all. In Indonesia, colorectal cancer is the second most common in males and third most common in females. So essentially, it's fairly equal in that sense. I don't think one is going to be, we don't necessarily associate colorectal cancer to be more common in one gender than the other. So both genders can be affected. Right. So age is another factor. And then obviously in certain families, maybe the family history of colon cancer or certain things where, there may be a higher risk. But that's honestly not as common, really. It's more common that there's no clear family history of such a problems at all, and it happens. Yeah.
Okay, thank you Dr. Robert Lim. Jadi untuk Ibu Nita mungkin resiko dari laki-laki atau perempuan tidak ada perbedaan yang signifikan, karena perempuan atau laki-laki sangat bisa terkena colorectal cancer ini. Mungkin Riri harap terjawab dengan jelas oleh Dr. Robert Lim. So I'm going to the next questions from Dr. Megawati Wijaya. So Dr. Robert Lim, how to diagnose colon cancer if there is no cancer, if there is cancer genetic in the family, and what if there is no typical symptoms, and how to diagnose the colon cancer?
So, one of the things as well that I didn't have chance to talk about is the issue of screening, right? So if there is, if you have someone or some person has a strong family history of colon cancer, so what do I mean by that? Typically, maybe there are other colon cancers in immediate family members, right? First generation, so parent or cousin, that kind of thing, uncle, in that kind of at that level. And younger age, typically, 40s, 50s, around that time, or, not as much, 70, 80, that has less impact. Those are scenarios where, of course, you ask the question of whether there could be something going on there. There are certain syndromes that we sometimes even consider doing genetic testing, but that test actually has to be done on a person who has the cancer to actually see whether that is present or not. For instance, what we call Lynch syndrome, that's one of the more common scenarios. But if there's a family, if there's even a history of, let's say, someone, just even a single family member diagnosed, let's say at 59, with colon cancer, well, if that person's maybe children, should get screening, at least 10 years earlier. But at the same time, I didn't get a chance to cover this. There's been an observation that there's been probably a greater number of younger patients being found to have colon cancer around the world these days. We still don't know exactly why that's happening. So in some places, that screening age has been moved from like 50 down to 40 as well. So colonoscopies obviously are actually one of the important ways of actually examining the colon, because if you find polyps, removal of polyps has been associated with a decreased incidence of colon cancer for such patients, right? Or obviously you hope that they may not have any symptoms yet, because actually if they have symptoms, it's usually a larger tumor already. But if they do not have symptoms but perform the screening and you find an early stage colon cancer, the outcomes, the chances of survival are also much better.
Oke, thank you Dr. Robert Lim. Jadi mungkin untuk menjawab dari pertanyaan dari Dr. Megawati gitu. Jadi mungkin screening atau deteksi dini itu sangat penting mulai dari umur 10 atau sampai 14 tahun untuk deteksi dari cancer colorectal cancer tersebut. Okay, so the next questions. I will ask personally, so my questions is most likely very basic since I am a woman in my 20s. And of course, as Dr. Robert Lim mentioned before, and as we know, lifestyle play a quite big role in colorectal cancer. So are there any specific types of food that are good for preventing the colorectal cancer?
So, there have been studies to look at the issue of fiber, right, in the diet. And by and large, I think it is a good thing to ensure. So making sure you have enough fiber, in your diet. Other than that, a lot of the other studies trying to look at various supplements and vitamins and all that, unfortunately, have not really shown that you can, make a difference that way. So I'm a big advocate in just saying that, look, a proper balanced diet, because think about it. How does nature work? Nature works about keeping things in balance. A bit of this and a bit of that. Too much is not good. Too little is not good, and we look at nature and we say that's how it works. So why shouldn't that be the same for us as well,
So we need to get balance in every
balanced approach.
Okay, so I'm gonna move to the next question. Thank you, Dr. Robert Lim, for the explanation. So the next question would be from Kevin. So the question is, why is colon cancer always being associated with stomach cancer and rectal cancer?
Okay, so no, colon cancer, I'm not exactly sure about your question, but there are some family syndromes where, like in Lynch syndrome, where not just colon cancer is a risk, but stomach cancer, bowel duct cancer, uterus cancer for ladies, but that's specific to Lynch syndrome. But someone who has colon cancer itself, we don't say and feel that there's actually a risk of stomach cancer itself, right? Now, if someone has had colon cancer and you've taken care of that early stage and they are well, it's very important that they continue their regular surveillance colonoscopy, because you see, whatever problem that led to the cancer developing in one part of the colon, you may have removed that, but the remaining colon will have that risk of developing a new colon cancer. So it's important to make sure you screen and check that as well. I hope that answers the question.
Okay. Okay. Okay, sorry, Dr. Robert Lim, for there's a sudden problem from the connection.
Okay, no worries.
So let's move to the next questions from Danik. So what is the effects of chemotherapy of a patient who have a uh, low pain tolerance? So
Sorry, low what?
a low pain tolerance.
No, there's no association with that. I mean, chemotherapy does not cause pain. Cancer can cause pain, right? If it is involving a certain area. Yeah. So chemotherapy, there may be side effects depending on which drugs we use as well. Okay, like I mentioned, oxaliplatin can have numbness issues if you give it repeatedly as well. Irinotecan, another common drug that we use, sometimes can have diarrhea possibility, but proper dosing and management of it can be helpful. Some of the antibody drugs I mentioned, the EGFR antibodies, they can cause skin issues, dry skin, pimples, actually, pimples. Unique side effects that we have to look out for and manage as well. Yeah, but by and large, I think that much of the chemotherapies that are used for colorectal cancer have very much manageable side effect range as well.
Okay, thank you, Dr. Robert Lim. So we are gonna go to the last questions. It's coming from Wahyu. So currently, I've been diagnosed with colitis infectious with colonoscopy, and still my stomach still not good. 3 months later, with colonoscopy, again I am diagnosed with bronchitis chronics. May I know what happened with my body? Is there any change
I
in
think
the
you need
future?
to, you
Gonna
need
be
I hope there's been a proper
colon.
evaluation, there's been scopes done to also take biopsies to actually also check and see. Colitis can be infectious, can be, right? That's what infection issues, that's one of the things, but it can also, like I mentioned, be this condition called inflammatory bowel disease. So recognizing which problem it is and therefore getting the right management for it is very, very critical. And if it's an infectious colitis, the risk of colon cancer from that, as we understand it at this point in time, is not necessarily increased beyond the usual general population. But if it's inflammatory bowel disease, Crohn's disease, or ulcerative colitis, then that needs a lot of proper management and proper follow-up to make sure it is, because over the years, that can sometimes be associated with an increased risk of colorectal cancer.
All right, Dr. Robert Lim, thank you for for all the answers. So before our webinar ends today, Riri, as the representative of Gracia Care, would like to thank all the audiences here, especially the Icon Cancer Center Cancer Center team, and also Dr. Robert Lim. In his busy schedule, he was still able to make time for the health talk with Gracia Care about colorectal cancer. And last but not least, thank you Bapak Binjaiban for always supporting us. So maybe before we end this health talk, we can capture the moment to take a picture together. Okay. Okay, let's count. 1, 2, 3. Okay, one more. Okay, 1, 2, 3. Okay, all right. Thank you so much for
Thank you for inviting
Icon
me.
Cancer Center, and of course, Dr. Robert Lim. Thank you for taking the time with us. I hope that we can be able to meet in any other changes. And bagi teman-teman, kalau mau tahu info lebih lanjut tentang Gracia Care, teman-teman di sini bisa lihat Instagramnya Gracia Care atau di website Gracia Care ya. And maybe is there any tips, Dr. Robert Lim, for us to preventing the colorectal?
Yeah, everyone asked, so, good healthy lifestyle as much as possible, the lifestyle risk factors, right? Take that into account, do what you can, right? Be active as well, all that kind of stuff. Diet is normal balanced diet. And I think the other thing, which again I didn't show any slides about it, is to go for screening at the appropriate time and age as well. Whether it is at least even a simple stool test to look for blood, that actually already has been shown that by doing that, if you find blood in the stool, then going for colonoscopy, that's one way. Or going for colonoscopies, to check, that's also been associated with benefits. So that's something I think, in terms of trying to do the best for ourselves, we can do that. Yeah. And hopefully, of course, nothing happens. But if there is, hopefully you find it early enough where treatment is actually easier with a much better chance of outcome as well. Yeah. Okay.
Oke, jadi mungkin secara garis besarnya memang basically our lifestyle really play a big role for this cancer. So teman-teman Gracia, bagi yang ingin berkonsultasi dengan Dr. Robert Lim bisa banget hubungi Gracia Care untuk for any consultation to Icon Cancer Center di Singapura ini bisa lewat Gracia Care untuk bertemu Dr. Robert Lim atau janji konsultasi rekomendasi apapun. Oke, di sini mohon maaf di sini kalau ada salah-salah kata atau ada yang tidak mengenakan diri sebagai perwakilan Gracia Care, izin pamit undur diri sampai ketemu di acara webinar Gracia Talk selanjutnya. See you on the next Gracia Talk, everyone.
Thank you.
Thank you, Dr. Robert Lim and Icon Cancer Center.
Thank you. Good night.
Good night.
Salam sehat teman Gracia, mau medical check up atau berobat di luar negeri? Gracia Care Global akan membantu Anda dalam memberikan referensi dokter dan rumah sakit yang paling tepat. Nah, melalui GCG, teman Gracia akan mendapatkan pelayanan prioritas seperti layanan konsultasi dan bantuan booking janji temu dokter. Gak hanya itu, GCG juga akan membantu proses perjalanan Anda dari awal loh. Mulai dari pemesanan tiket pesawat, hotel, dan penjemputan di bandara, sampai pembelian asuransi perjalanan. GCG juga menyediakan layanan pesawat charter bed-to-bed yang berkualitas. Buat teman-teman Gracia Care yang suka jalan-jalan, gak perlu bingung. GCG membuatkan itinerary atau panduan perjalanan yang berisi jadwal janji temu, tempat-tempat wisata, dan juga kuliner. Setelah selesai berobat, untuk teman Gracia yang memakai asuransi, GCG akan membantu mempercepat proses penjaminan dan memastikan dokumen-dokumen yang kamu perlukan dari rumah sakit lengkap. Jadi, teman Gracia nggak perlu repot deh.
Thank you Gracia Care yang sudah membantu saya dan keluarga besar saya dari Jakarta, Malaysia, Pining sampai ke Singapura. Saya dan keluarga besar saya merasa terbantu banget sama fasilitas dari Gracia Care. Ya awalnya kita nggak ngerti cara daftar gimana atau dokter mana sih yang terbaik buat keluarga saya. Gracia Care sangat membantu dan juga menjawab segala kebutuhan saya. So thank you banget buat Gracia Care. Dan jangan lupa dengan menggunakan fasilitas Gracia Care dapat diskon loh. Bahkan saya dapat update tambahan kelas nambah lebih baik lagi. Thank you banget buat Gracia Care. So buat teman-teman yang masih bingung, ragu pakai Gracia Care atau tidak, jangan ragu karena saya dan keluarga besar sudah memakai Gracia Care. Thank you.
So how I became an oncologist has a very personal touch. My mother was diagnosed with cancer many years ago, and that whole experience and journey, was touching and revealing, and it showed a different side of medicine, which made a big impact on me. The thing that stood out in oncology care was that it's definitely a journey that the patient and the family embark upon as well. So I've seen the changes in oncology over the past 2 decades, from a single choice of one drug or no choice at all to 2, 3, 5, 6 drugs and combinations of such as well. It can be a bewildering effort to try and figure out what needs to be done. Being able to help our patients make choices for themselves can make a big difference. And all those years has given me a breadth of experience, I think, to be able to know that I've seen various shades of how cancer issues may present and how to deal with issues of such for patients and their families. It brings me joy to make sure that I can get them through those tough periods, knowing that we've made a difference that day, made a difference that week, and made a difference for the patient and their families.
Salam sehat teman Gracia. Mau medical check up atau berobat di luar negeri? Gracia Care Global akan membantu Anda dalam memberikan referensi dokter dan rumah sakit yang paling tepat. Nah, melalui GCG, teman Gracia akan mendapatkan pelayanan prioritas seperti layanan konsultasi dan bantuan booking janji temu dokter. Gak hanya itu, GCG juga akan membantu proses perjalanan Anda dari awal loh. Mulai dari pemesanan tiket pesawat, hotel, dan penjemputan di bandara, sampai pembelian asuransi perjalanan. GCG juga menyediakan layanan pesawat charter bed-to-bed yang berkualitas. Buat teman-teman Gracia Care yang suka jalan-jalan, gak perlu bingung. GCG membuatkan itinerary atau panduan perjalanan yang berisi jadwal janji temu, tempat-tempat wisata, dan juga kuliner. Setelah selesai berobat, untuk teman Gracia yang memakai asuransi, GCG akan membantu mempercepat proses penjaminan dan memastikan dokumen-dokumen yang kamu perlukan dari rumah sakit lengkap. Jadi, teman Gracia nggak perlu repot deh.
Thank you Gracia Care yang sudah membantu saya dan keluarga besar saya dari Jakarta, Malaysia, Pining sampai ke Singapura. Saya dan keluarga besar saya merasa terbantu banget sama fasilitas dari Gracia Care. Ya awalnya kita nggak ngerti cara daftar gimana atau dokter mana sih yang terbaik buat keluarga saya. Gracia Care sangat membantu dan juga menjawab segala kebutuhan saya. So thank you banget buat Gracia Care. Dan jangan lupa dengan menggunakan fasilitas Gracia Care dapat diskon loh. Bahkan saya dapat update